Cardiovascular system.
Cardiomegaly, or the enlarged heart. Cardiomegaly is not a disease, but rather a symptom of another condition. It's generally correlated with cardiac failure, which is the result of a decreased ability of the heart to contract or increased pressure volume load. To treat cardiomegaly, you must treat the underlying reason for it. Treatments can include medication, medical procedures, or surgery. The important thing to remember about this is that cardiomegaly is not a disease. So we can see other things that cause cardiomegaly. However, we will never see cardiomegaly actually as a disease. There's always something causing it. And many times we look at a basic chest x-ray and see cardiomegaly. This technique, which is probably a portable, we see that the heart is very much large in relation to the chest, and that is the surefire symptom of cardiomegaly. However, many times portable techniques amplify and magnify the heart, increasing its size in relationship to the chest. The etiology of cardiomegaly. Sometimes cardiomegaly occurs for unknown reasons, meaning that it's idiopathic in nature. However, known conditions that cause cardiomegaly are hypertension, heart valve disease, cardiomyopathy, myocardial infarction, congenital heart defects, arrhythmia, pulmonary hypertension, anemia, thyroid disorders, hemochromatosis, and even pregnancy. The associated symptoms of cardiomegaly. In some people, an enlarged heart causes no signs or symptoms. Others may exhibit these symptoms: shortness of breath, dizziness, arrhythmia, edema, cough, chest pain, and syncopal episodes. Primarily, many times the classic symptoms of cardiomegaly are shortness of breath and edema, and sometimes even chest pain. These are simply what we know to be symptoms of other things as well, such as congestive heart failure, and they fit very closely with cardiomegaly. So the workup for diagnosis for cardiomegaly. Generally, the workup is not to determine if cardiomegaly exists, but rather why it exists. Methods of determining this are a simple chest x-ray, electrocardiogram, echocardiogram, stress test, cardiac CT, laboratory test, and cardiac catheterization. Primarily, a chest x-ray usually will suffice. However, if chest x-ray will not suffice, many times we see that those chest x-rays are labeled as abnormal, and that pretty much opens the pathway to do a cardiac CT or just a plain chest CT without contrast. As we are concerned with pathology relating to CT, let's assume that this patient has an abnormal chest x-ray or an enlarged heart on a portable chest x-ray. To determine the presence of cardiomegaly, then, when the patient is actually taken to CT, we have to look at the cardiac to chest ratio. The cardiac to chest ratio must be less than 55%. Cardiomegaly is associated or assessed by measuring transverse diameter of the heart as well as transverse diameter of the chest. So here we have the transverse diameter of the heart, and here we have the transverse diameter of the chest. And so we see that the transverse diameter of the heart must be less than 55% of the total transverse diameter of the chest. In this image, we see that the measurements have already been given for us. We have a 13.709 centimeter measurement for the chest, or for the heart, and we have a 20.206 centimeter transverse diameter for the chest. So if we were to take 13.709 and divide it by 20.206, we would actually come up with a measurement of around 67% of the total chest width that the heart is comprising. Just even a simple look at this would illustrate to us that this person has cardiomegaly, and So we assume that that is the case for this patient based on our measurements. In this image, we actually don't have the measurements provided for us, but if we were to just take a rough estimate and draw a line from the chest, one side to another, we would come up with a transverse diameter once again of the chest, and we would do the same thing for the heart and come up with the transverse diameter of the heart. However, if we were just looking at this, we would see that the heart looks primarily enlarged, not as much as the previous image, but still probably greater than 55%. But that is where we need actual measurements to do so, and that's why CT provides such an ample and adequate resource to do that in. Moving on now, we have congestive heart failure, or CHF, as we'll call it. Congestive heart failure simply means that the heart can't pump enough blood to meet the body's needs. The term comes from blood backing up or congesting around the liver, abdomen, lower extremities, and even the lungs. Many conditions that lead to heart failure can't be reversed, but congestive heart failure can be treated. And that is an important thing to remember. Once the damage is done, it can't be reversed, but we can actually treat the symptoms of it. And we do this through the use of medications, which help to reduce the signs and symptoms of heart failure. But moreover, we do this through lifestyle changes to help improve the quality of life. These types of lifestyle changes can range from exercising to reducing sodium intake, managing stress, and even losing weight. And so each of these will have a large impact on the patient's status and also on how the congestive heart failure actually works and affects the body. But we see that many times exercising and reducing sodium intake will have the same effect of losing weight, and through that the patient will actually have a higher quality of life. We should also understand that congestive heart failure has different classifications and different stages. There are two scales that are used to help classify and quantify where the patient is in relationship to their congestive heart failure. The first stage is the New York Heart Association, or the NYHA classification scale. We see that in NYH Class 1, you don't have any symptoms and no limitations during physical activity. So pretty much you have no symptoms. And so that's the important thing to keep in mind here, that no symptoms are present. On the NYH Class 2 scale, you only have mild symptoms, and they're only occurring during physical activity, and you're always comfortable at rest, and there's really no limitation, only slightly. So remember that classification 2 yields slight limitations. Then we get into the advanced stage heart failure. The NYH Class 3, there is a noticeable limitation due to symptoms even during minimal activity. The important thing to distinguish here is that you are still comfortable at rest. However, on the NYH Class 4, you have severe limitations. You experience symptoms even while at rest, such as sitting in a recliner or watching TV. So even when you're at rest, you have these symptoms, and you really cannot get any relief from them. The second scale that we'll look at is the American College of Cardiology and the American Heart Association classification scale. In this scale, it's a little more straightforward than the New York Heart Association scale. And we have, just like the NYHA scale, we have early stages and then later stages. Stage A, in the early stage, it means that you're at risk for developing heart failure without evidence of heart dysfunction. So in stage A, primarily think about it and look at it as a type of stage where we all pretty much kind of fit into, where we have a family background or genetic predisposition to actually having congestive heart failure or heart disease, but we actually haven't got there yet. We're still a long ways off from it. In stage B, that's when we actually begin having symptoms associated with heart dysfunction. And so we actually start getting that. The advanced stage, heart failure, we have stage C and D. Stage C is when we have evidence of heart dysfunction with symptoms. And notice the difference between Stage B and C is simply symptoms. With stage B, we have no symptoms, and stage C, we have symptoms. So in stage C, that is when we start seeing that it actually starts affecting our life and starts affecting how we do things. Then we get to stage D, and symptoms of heart failure despite maximal therapy. And so you're taking medicine, you're doing everything you can to actually achieve better heart function. You've changed your diet, you've lost weight, and you've reduced your sodium intake, but you're still not able to actually function correctly. And because of this, we see that stage D is very much associated with stage 4 on the NYHA scale. And so you're never really going to be comfortable no matter what you're doing. If you're watching TV, sitting in your recliner, doesn't matter. Also, it's very important for us to realize that there are different types of heart failure. Every heart failure is not simply the same. We have left and right-sided heart failure. And in this, we notice that there's a difference. In the left-sided heart failure, fluid backs up into the lungs. And primarily this is because the left side of the heart is in charge of getting the blood out of the lungs and actually pumping it through the aorta into the abdomen. And because of this, we actually see that when you have a left-sided heart problem, that the blood's not actually coming back into the heart from the lungs, and so it has a tendency to pool in there. And so always think of left-sided heart failure as being in relationship to the lungs and fluid primarily. Right-sided heart failure is much different. It occurs with many times left-sided heart failure. So many times left and right are linked, and when you have one, you have another. However, the difference with right-sided heart failure is that fluid backs up into the abdomen, legs, and feet. So notice that most of the time with right-sided heart failure, you're going to have edema in the legs. And so this is pretty much self-explanatory as well, because the right atrium and the right ventricle are in charge of getting the deoxygenated blood from the superior and inferior vena cava and actually pumping it out into the lungs. When they have a problem, the fluid has to go somewhere and it backs up into the abdomen. Also, we have a systolic and diastolic heart failure. The systolic is when the left ventricle can't contract vigorously, and it indicates a pumping problem. So memorize that, keep that in mind, that systolic heart failure equals a pumping problem. Diastolic heart failure, the left ventricle can't relax or fill fully, indicating a filling problem. That will become very handy for you. Additionally, we see that there are other stages of congestive heart failure that are really not classifications of a certain type of scales, but just classifications in general. We see that in stage 1 of congestive heart failure, we see redistribution of pulmonary vessels, and then we have cardiomegaly. This is one of the earliest signs of congestive heart failure, and we see that usually when you do have congestive heart failure, your heart has to enlarge itself to actually overcome its inefficiencies. Stage 2, we have curly lines, peribronchial cuffing, hazy contour vessels, and thickened interlobar fissures. And so the things to really look at is the haziness and the thickened interlobar fissures. Stage 3, we do have alveolar edema. We have consolidation, air bronchogram, cotton wool appearance of the lungs, and pleural effusion. And so the last two are what we really focus on, the cotton wool appearance and the pleural effusion. So keep these things in mind and be sure to look for them when we actually look at images. The etiology of congestive heart failure. Congestive heart failure is caused by other conditions that weaken the heart. And much the same way that cardiomegaly is a symptom, congestive heart failure is a symptom of other and underlying diseases. It can be caused by the ventricles becoming stiff and not filling properly. The ventricles can dilate, making it difficult for the heart to pump blood. And it can be caused by coronary artery disease, myocardial infarction, hypertension, heart valve abnormality, cardiomyopathy, myocarditis, congenital defects, and arrhythmias. However, we typically associate congestive heart failure with coronary artery disease, myocardial infarction, and hypertension. Those are the three things that we typically associate congestive heart failure with more so than others. In this image, we see the actual effects of congestive heart failure and other things on the heart. In the normal heart here, we actually see that the atria here and here are quite normal in size, as are the ventricles. However, if we actually look at the dilated or enlarged heart, we see that the atria have pretty much doubled in size, becoming ballooned out, and as a result, the ventricles have actually enlarged as well. And so, primarily, our normal and the greatest concern is in the fourth ventricle. And if we see that, or not the fourth ventricle, but the left ventricle, if the left ventricle is enlarged to the extent that it has become ballooned out here, we see that actually the heart pumping becomes very, very inefficient, and it takes more effort to overcome the forces needed by the heart to actually pump the blood. So we can see that the heart has pretty much enlarged, and if we were to look at the heart in its overall image here in comparison with this, we see that our dilated heart also has cardiomegaly. So it's very well understood that cardiomegaly is just an associated thing that goes with congestive heart failure. Symptoms of a patient who does have congestive heart failure. We must first understand that there are chronic congestive heart failure symptoms and acute congestive heart failure symptoms. Chronic symptoms simply mean that those symptoms have not developed recently, but they have developed over the course of time, and the patient has had to continue dealing with them. Acute symptoms, more or less, actually develop pretty recently, almost instantaneously, and kind of unexplained. So some of the symptoms of chronic congestive heart failure are dyspnea, fatigue and weakness, swelling or edema in the legs, ankles, and feet, rapid or irregular heartbeat, reduced ability to exercise, persistent cough or wheezing with white or blood-tinged phlegm, ascites, sudden weight gain from fluid retention, lack of appetite and nausea, difficulty concentrating, or decreased alertness. Typically, you see patients who have congestive heart failure experience dyspnea, fatigue and weakness, swelling, reduced ability to exercise, and I would also say that reduced ability to exercise even can go so far as simply getting up out of the bed. And so that quantifies as exercise to these patients and can be very, very difficult to actually accomplish. They also do have ascites many times, which goes back to the swelling or edema in the legs, and they do have sudden weight gain. Many times that is why Lasix is administered, to hopefully cut down on that fluid retention and decrease that. So the acute congestive heart failure symptoms are more or less similar to congestive heart failure being chronic. However, they do seem to appear more rapidly. Symptoms are similar to those of chronic heart failure, but more severe and start to worsen suddenly. So acute symptoms tend to be more severe and worsen suddenly. So these patients start experiencing symptoms and rapidly decline from there. They have sudden fluid buildup, rapid or irregular heartbeat, which we call palpitations, sudden or severe shortness of breath, and coughing up pink foamy mucus. Many times they have chest pain if heart failure is caused by a heart attack. And many times we can see that a patient who has a heart attack and decreased ability of the heart to pump, we do see that they have tremendous chest pain, and then that leads to other functions and symptoms. So to understand if a patient has congestive heart failure or not, we see that there are many avenues that people can take to diagnose this. Primarily lab tests in general have a really good indicator of this, such as CBC, cardiac triage, metabolic panels, and BMP. The cardiac triage is very, very nice to have, because what this does is allow you to see if the patient is experiencing a heart attack or not. And if there's elevation in troponin levels, then this can be indicative of other things underlying why the patient has gone into heart failure. Chest x-ray is usually used to indicate whether the patient has cardiomegaly and if there is fluid retention in the lungs. ECG, or as we call EKGs, echocardiogram, and it's important to note here that the ejection fraction for a normal heart should be around 55 to 75%. What we understand to be the ejection fraction is how much blood the heart actually pumps out in relation to what it takes in. And so you typically want the heart to be removing 55 to 75% of all fluid that actually comes into it. However, if you drop below this, then that can be an indicator of congestive heart failure. So keep this number in mind here. Also, a stress test, chest CT, and cardiac catheterization. Many times, chest x-ray and lab work will suffice to diagnose congestive heart failure, which will then lead to echocardiograms and cardiac caths. Chest CT sometimes does not play a tremendous role in the diagnosis of congestive heart failure, because other means and avenues tend to do it equally as well. In terms of looking at congestive heart failure from a computer tomography standpoint, we have to look at many of the overlying symptoms and what is actually occurring here. If we look at this image, we do see that the heart is not as great in size as what many of the images that we've saw. So this patient does not have significant cardiomegaly. However, if we look at the bottom portion of the lung fields, we do see that we have a tremendous amount of changes here. Greater on the right hand side than on the left. If we were to consider what this is, we know that there has to be a fluid aspect to it, because if we look at CT, air always has the density or the color of black. High density materials always have, such as bone, always have the appearance of white. And so fluid always is somewhere in the middle. It's a gray area. And so we must assume that this is fluid on both sides of the patient, both right and left lungs, with greater on the right hand side. And so while we don't see cardiomegaly, we do see some fluid in the lungs, which can be indicative of congestive heart failure. In this image, we also see a right-sided pleural effusion here, and this fluid in relationship is not seen on the left-hand side or the left lung, and so this person probably doesn't have as great of congestive heart failure as the previous patient. However, there is also something here in the lung which begs to be looked at. We don't really know what this is. It could just be a fissure, but it also could be something underlying in the lungs. So this could be congestive heart failure caused by other things, such as a certain type of medication, cancer, things of that nature. So that brings us to coronary artery disease. Coronary artery disease develops when the coronary arteries become damaged or diseased. Plaque comprised of cholesterol is usually the attributing factor leading to coronary artery disease. This plaque causes stenosis of the arteries and can eventually lead to complete occlusion. However, this can be prevented by a healthy lifestyle. One thing to keep in mind here, that while we assume that coronary artery disease can be prevented by a healthy lifestyle, we also must look at genetics and familial disposition to see whether complete prevention can be acquired. I am on the side of favoring that genetic predisposition tends to demark one's course in terms of coronary artery disease. If your family has a history of congestive heart failure, coronary artery disease, things of this nature, things that weaken the heart and can cause severe damage, then it seems to be evident or self-evident that many times this tracks alongside of your disposition as well, and you will ultimately wind up with these conditions. So there can be genetic predispositions here. In looking at coronary artery disease, we must first understand that we have a right and left coronary artery. The right coronary artery doesn't have as many bifurcations, whereas the left coronary artery has many. The left coronary artery becomes the anterior interventricular artery, and we see many other bifurcations. To understand the basis of coronary artery disease, we must also understand what normal and narrowing of the arteries actually looks like. As we can see here, we have a normal artery. In this normal artery, we have a normal lumen, and we have a very nice passageway through the artery. As we can see on the interior, there is no clogging, nothing that is going to restrict or impede the blood flow. So we can fill pretty much all the vessel up with blood. However, in this image, we see that we have an artery that has quite a large amount of plaque inside of it. Not so much in this area here and here, but the area that is mostly compromised is this area. And as we can see, we can get quite a lot of blood to go through this area, but when we get to this area, it creates a stricture, which ultimately winds up compromising what can go through. And hypothetically, if we were to have a clot, as we know blood sometimes produces, such as this, heading towards this area, we ultimately get this image. And as we can see here, while this portion of the artery still maintains blood, this area of the artery has no blood going to it. And so we must imagine that if this is going to the heart, then this portion of the heart here will actually have damage done to it simply because of this clot and not allowing blood to go through. So this creates a thrombosis. So the etiology of coronary artery disease. Coronary artery disease is thought to begin with damage or injury to the inner layer of the coronary artery, sometimes as early as childhood. The damage may be caused by various factors including smoking, high blood pressure, high cholesterol, diabetes, radiation therapy to the chest as used for certain types of cancer. And so if we look at these, there are a few things that we actually have control of. We actually have control of smoking, our cholesterol, and diabetes. Smoking is a choice that we make. Either we choose to smoke or we choose not to. High cholesterol, we can change this by dieting. And diabetes, many times when we're speaking of this, is referred to as type 2 diabetes, in which you can actually modify this simply by working out and changing your lifestyle. So many of these factors we can actually change and modify, which will hopefully decrease the risk of coronary artery disease. The exercising will actually hopefully decrease blood pressure as well, and so we can control or mitigate some of these factors. However, if we discover that there's a strong genetic disposition for coronary artery disease, then this pretty much nullifies these factors, because you're going to get coronary artery disease regardless. And so we have to be mindful that there can always be a genetic disposition here. So to understand coronary artery disease, I feel that it's important for us to understand how plaque actually accumulates inside of the artery. So once the inner wall of an artery is damaged, fatty deposits or plaques made of cholesterol and other cellular waste products tend to accumulate at the site of injury in a process called atherosclerosis. If the surface of these plaques breaks or ruptures, blood cells called platelets will clump at these sites to try to repair the artery. This clump can block the artery, leading to a heart attack. And so basically what happens is the wall of the artery is damaged. And as we saw, sometimes that can even occur congenitally or at a very young age. And because of this, plaque tends to accumulate there. And because plaque tends to accumulate at these rough spots, when the plaque tends to break off or move in the artery, the body senses this and sends platelets to this area to repair this damage. This type of repair mechanism will then create a clot, which will sometimes get stuck in these plaque areas and then ultimately lead to a heart attack. So it's because of the body's natural defenses that sometimes we actually have a heart attack. So the symptoms of coronary artery disease. Many times we see that patients actually have angina, dyspnea, sometimes a crushing pressure on the chest, and pain in the shoulder or the arm. And so if we notice this, these are pretty much symptoms of a heart attack. The most being angina, crushing pressure on the chest, and pain in shoulder or arm. However, we must also distinguish that men and women experience varying degrees of these symptoms, and many times men and women don't actually mirror the same symptoms for the same problem. So while these are supposedly the standard symptoms, there can be other symptoms such as pain in the mandible, things like this, that will actually dictate that you're having a heart attack as well as these symptoms. So the workup for diagnosis. We first begin with lab work, such things as a CBC, metabolic panel, cardiac triage, and another thing that can be very helpful in this situation is a PTT. So on your notes, write down PTT here as well. We can also use ECG or an EKG, electrocardiogram, stress test, cardiac catheterization, CTA, and MRA. And so many times you'll find patients that have coronary artery disease coming through the ER, and many times they'll have lab work, ECG, and a chest X-ray. And many times this will be indicative of making a firm diagnosis of possibly what's going on. And many times the patient is actually just taken in for cardiac catheterization after that. To gauge CT or coronary artery disease, many times cardiac catheterization offers you the ability to provide interventional means as well as a diagnostic means. So in terms of looking for coronary artery disease on CT, we see that CT angiography is not sensitive enough to grade coronary artery stenosis, precisely because of the small size of these vessels and considerable problems with pulsation effects. So keep that in mind, that CT angiography is not sensitive enough to grade coronary artery stenosis. And it's simply because of the vessels that we're dealing with are very small in size. So the grading scheme for coronary artery disease is as such. 0 or grade 0 is 0%, which is normal. Grade 1 is 1 to 49%, and this is non-obstructive disease. So hypothetically, with non-obstructive disease, you're going to be okay. You're not going to be as good as normal, but chances are nothing's going to actually happen due to this plaque. Grade 2 is 50% to 74%, and this is significant stenosis. Grade 3, 75 to 99% is high-grade stenosis. So the chances of something occurring here at high-grade stenosis are very, very clear. Stage 4 is going to be occlusion, complete occlusion leading to disastrous implications with possible areas of the heart experiencing cellular death. Suspicious areas must be analyzed from 2 perpendicular planes. And when we're saying this, we need one plane like this and another like that. And so if we were looking at it, we would have a sagittal and a coronal, perhaps, or a coronal and an axial. Things like this will help us gauge the coronary arteries. Regions with motion artifacts should be excluded from the evaluation. So underline this because that is very important. that we understand that anything that has motion on it cannot be diagnostic in quality. And so the normal arterial wall measures 0.1 millimeter and is not visible on CTA. So therefore CTA cannot see the artery wall and therefore must rely on other extenuating factors. So here we have a 3D reconstruction of coronary artery angiography, and in this we see that we have pretty much the right and left coronary arteries here, and as we can see, we cannot see the stenosis here. We are simply relying on filling defects, which based on this image there appears to be none. However, this image does not appear to be very helpful in the relationship of coronary artery disease engaging it. Here's another demonstration of the coronary arteries. We have the left here and the right here, and as we can see, once again, it's very difficult to discern what is actually filling defects and not. As we can see at the more distal tips here and even here, we have a haziness that almost looks like a filling defect. However, how can we be certain that this is actually that? What we rely on in terms of CT is, or CTAs in terms of volume rendering such as this, are complete filling defects. And when we speak of filling defects, we mean something like this portion is not showing up. We're not seeing this area here. And so we rely on significant filling defects for 3D reconstruction, which sometimes is not always the case. This view, taken more along the lines of an oblique plane, tends to be more accurate and more demonstrative of coronary arteries and potential diseases. As we can see here, we have plaque here, 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 and here. However, what we don't actually have the ability to do is gauge whether these areas of plaque are causing a stenosis. Once again, we're still relying on a filling defect, which there does not appear to be a filling defect, simply because we have contrast extending out here, coming all the way here. And also we have contrast flowing down through all the bifurcations at this level as well. And so the only thing that we could possibly argue that there is a potential stenosis is in this area and this area here, because we don't see that they have actually highlighted as well as the other coronary arteries. And so Pericardial effusion. The heart is surrounded by a double layered sac-like structure called the pericardium. The space between the layers normally contains a very small amount of fluid. When a pericardial effusion exists, there is an excess of fluid around the heart. When the volume of the fluid exceeds the pericardium's full level, the pericardial effusion can place pressure on the heart, which causes cardiac tamponade. Poor heart function, heart failure, and even death can be the end result of this. Looking at this image, we see several key things. We have the myocardium and the endocardium, which you will recognize as layers of the heart. We do have a parietal pericardium and a visceral pericardium. And so as we can see, the visceral pericardium pretty much lies over the heart and creates another lining, whereas the parietal pericardium actually exists and is attached to an adjacent fibrous capsule or a layer. In between the parietal and the visceral pericardium is the pericardial cavity. As we can see here, the pericardial cavity creates this cavity that allows potential fluid to build up here. And some degree of fluid is good simply because it decreases the amount of friction upon the heart and allows the heart to beat at an appropriate level. However, if there's too much fluid that actually accumulates here, we see that the fibrous layer will not allow there to be much give in terms of pushing out. So if there's too much fluid, there's nowhere for it to go but in. And so because it presses inside instead of pressing outside, there's tremendous force exerted on the myocardium, endocardium, and basically ultimately winds up compressing the heart and not allowing the heart to beat and function as properly. So the etiology of pericardial effusion. Inflammation of the pericardium, such as pericarditis, is a response to disease, injury, or an inflammatory disorder that affects the pericardium. Pericardial effusion is a sign of this inflammatory response. Pericardial effusion may also occur when the flow of pericardial fluids is blocked or when blood accumulates within the pericardium. It's not clear how some diseases contribute to pericardial effusion, and sometimes the cause can't be determined. Hypothetically, some of the specific causes of pericardial effusion could include viral, bacterial, fungal, or parasitic infections, inflammation of the pericardium due to unknown causes, labeled as idiopathic pericarditis, inflammation of the pericardium following heart surgery or heart attack, autoimmune disorders such as rheumatoid arthritis or lupus, waste products in the blood due to kidney failure, hypothyroidism, HIV or AIDS, metastasis, particularly lung cancer, breast cancer, melanoma, leukemia, non-Hodgkin's lymphoma, or Hodgkin's disease, cancer of the pericardium or heart, radiation therapy for cancer if the heart was within the field of radiation, chemotherapy treatment for cancer such as doxorubicin and cyclophosphamide, trauma or puncture wound near the heart, certain prescription drugs including hydrazolinine, a medication for high blood pressure, isoniazid, a tuberculosis drug, and phenytoin, dilantin, Fintech, and others, a medicine for epileptic seizures. So some symptoms of pericardial effusion are dyspnea, shortness of breath when lying down, chest pain usually behind the breastbone or on the left side of the chest that often feels worse when you breathe and feels better when you're sitting up rather than lying down, cough, painful breathing especially when inhaling or lying down, fainting or dizziness, low-grade fevers, rapid heart rate, or an overall feeling of anxiety. However, the one that seems to make the most sense is chest pain, simply because the heart is being compressed due to the nature of the pericardial effusion. However, many times these symptoms mirror other things such as heart failure or heart attack. And so many times the workup is not simply for pericardial effusion, but to rule out other factors as well. So the workup for diagnosis, number one is a routine medical examination. Many times simply by listening to the patient's lungs and the heart, using a stethoscope, this will indicate some abnormality there. Also echocardiogram, transthoracic or transesophageal. However, many times due to the nature of smaller hospitals, many times it's difficult on certain times of the day and certain days of the week to actually obtain an echocardiogram. So many times this comes actually later. ECG, just to rule out any other abnormalities such as the electrical parts of the heart. Chest X-ray, many times this will be indicative of an enlarged heart shadow, and because of this, it gets ruled as an abnormal chest X-ray, which then opens the door for CT of the chest. And on CT of the chest, we actually see this pericardial effusion very well, and due to the nature of it, we can actually gauge it very well as well. So what does it actually look like on CT? We see that CT is very sensitive for the detection of pericardial fluid, especially anterior to the right ventricle and posterior to the left ventricle. So remember this, that typically you're going to see, in terms of CT, many times pericardial effusions going anterior to the right and posterior to the left ventricles. Little pockets of fluid with smaller than 5 millimeters next to normal regions of thin pericardium are normal, but become abnormal if the fluid encircles the heart. And so what we're looking for is small amounts of fluid are okay. However, if the fluid actually encircles the heart, then that is where the problem lies. Okay, in this image, we do have several things that we must recognize. We do have the interventricular septum running here. So keep that in mind. So this means that this is the right ventricle and this is the left ventricle. And so we assume that this area here is the heart. And so if we determine that to be true, then we understand that we have this area here and this area at the posterior portion of the heart. And if we'll notice, this fits very well with what we know to be the case with pericardial effusion, because we have a large amount of fluid anterior to the right ventricle and posterior to the left ventricle. And so that is the typical manifestation that we're going to see for pericardial effusions. However, it should also be noted here that we have something actually going on at the lung basis. We have thickening here, and so who knows what the patient is actually going through. There could be some underlying reason for this pericardial effusion that we're not made known of. Okay, on this image, also make known or make note of our location here. We're actually scanning out of the lungs and we're going almost into the liver, so we're seeing the diaphragm actually come in. We actually have the heart residing here, and we assume that based on our location, this is going to be the right ventricle. And if this is the right ventricle, we see that we have a large amount of fluid, very large, going anterior to the right ventricle. Due to this, we see that the heart, this could also be due to simply where we're at in location and in respect to the heart. However, it does seem like the heart is compressed to a certain degree. And as we can see, the pericardial effusion is very, very large. And so we assume that this has to be affecting the heart and its pumping mechanisms. There's no way that it could not be. So therefore it makes the heart actually less efficient, because the heart can't fully expand to allow full filling, and so it's always almost in a state of contraction. So therefore pericardial effusions are very detrimental to patients' health. On this image, we see that it's slightly more difficult to actually see where we're at in respect to the heart. However, we do see that the heart shadow is very, very obvious. We do see that we have the interventricular septum here, and this divides the right from the left. And so, based on this, we do see that we have some degree of pericardial effusion. We do have some on the right and some posterior. However, if we'll notice, the heart still retains its almost normal size, and so it's not as indicative in this case of being a true detriment as it has been in others. However, that's not to say that this pericardial effusion will not grow and create problems in the near future. So it would be very pertinent to actually keep this in check and keep it monitored. So, cardiac transplantation. A heart transplant is an operation in which a failing, diseased heart is replaced with a healthier donor heart. Heart transplant is a treatment that's usually reserved for people who have tried medications or other surgeries, but their conditions haven't improved sufficiently. The general indications for cardiac transplantation include deteriorating cardiac function or having a prognosis of less than 1 year to live. So keep that in mind, that you have a deteriorating cardiac function or prognosis of less than 1 year to live. And so there's nothing that can be done to assist you, because pretty much everything's been exhausted. All the medications, everything that potentially could have worked didn't. And so that's where we see people needing heart transplants. So the etiology. The disease processes that require cardiac transplantation can be divided into the following categories. We have idiopathic cardiomyopathy, ischemic cardiomyopathy, and congenital heart disease. Idiopathic cardiomyopathy comprises about 54% of all cases, which is just simply weakening of the heart muscle due to unspecific causes. And ischemic cardiomyopathy makes up the other large percentage, being around 45%. This is weakening of the heart muscle as a result of coronary artery disease. And lastly is congenital heart disease and other diseases, which comprise around 1%. So the real thing to keep in mind here is that idiopathic cardiomyopathy has around 54% of all cases, meaning that many times we don't even know what causes the heart muscle to fail. We only know that it fails and we see the results of it. However, many times we contribute it to coronary artery disease, but keep in mind that this is only around 45% of cases. There's many cases that we simply don't understand. Specific indications include dilated cardiomyopathy, ischemic cardiomyopathy, congenital heart disease for which no conventional therapy exists or that conventional therapy has failed, ejection fraction of less than 20%, intractable angina or malignant cardiac arrhythmias for which conventional therapy has been exhausted, and pulmonary vascular resistance of less than 2 Wood units. The one thing to keep in mind here is the ejection fraction of less than 20%. Keep in mind that the ejection fraction typically should be around 55 to 75%. And so we see a rapid decrease in the ejection fraction. It is also very important that we understand ejection fraction. Ejection fraction simply means that the heart is able to pump out as much fluid as it can from itself. So if the heart takes in 100 milliliters of blood, the heart should at least be able to pump out 55 to 75 milliliters. If it's only pumping out 20 milliliters, then that is where we actually have things backing up, not going where we need them to, and so that's why we have left and right-sided heart failure, simply with fluid accumulating in the abdomen and in the lungs. And so that decreases the amount of life and the lifespan of the patient. And so it's very, very indicative of where that patient is heading. If the ejection fraction gets even lower than 20%, we assume that the patient is not going to have the ability to do much to function in life. And so that is why it is necessary to replace the diseased heart with a very healthy heart. So the symptoms for cardiac transplant are very much similar to those for congestive heart failure, because cardiac transplantation and the need for cardiac transplantation very much mirrors congestive heart failure. So some of the ways that we determine cardiac transplantation is lab tests to see how the heart is actually functioning, and also lab tests to discern what type of blood, what RH factor, things of that nature. Also, we have an echocardiogram, chest x-ray, pulmonary function test, cardiac catheterization. And notice that chest CT is not on here, simply because many times chest CTs are done after the fact, because if the patient is known to have heart failure in need of a transplant, then chest CTs really do little to dissuade that. Okay, so the way that cardiac transplants actually look on CT, I'll have to explain this because I was not able to find a heart transplant CT that was of good quality to actually show you. So cardiac transplants actually tend to roll towards the left due to the surgical restructuring of the chest. And so typically that's what you're going to look for. In the other images we saw how the heart actually looks, and so when you have cardiac transplant, the heart tends to favor the left side and kind of roll over towards the left side. So it'll look very abnormal, and usually patients will be very forthcoming with the information. They'll be very forthcoming with that information to tell you that they have actually had a heart transplant and things of that nature. However, one of the things that I feel that we will be seeing more of as time passes is ventricular assisting devices, and that's what we actually have here. We have a left ventricular assisting devices as demonstrated by this picture, and we see a 3D reconstruction here, the SIR view or the scanogram here, and then just kind of removal of detail just to allow us to see the device there. And so basically what we have here is the left ventricular assisting device, which means pretty much that the patient has had their left ventricle have some abnormalities. Perhaps the left ventricle has become stretched and dilated to the point to where it cannot contract enough to generate enough force to actually pump the blood out. And so what we have here is this ventricular assist device actually allows blood to circulate in a better manner through the ventricle and allows it to pump at a higher efficiency. And so it removes some of the stress for that ventricle. And the reason I feel that we'll see more of this is because many times we have patients that actually pass away waiting on a heart transplant. As we must remember that these are not things that you simply go out and buy, but these things must be donated, and there has to be a certain criteria that must be met to actually achieve the transplantation. And so many times patients don't have the amount of time that is needed to actually get to the transplantation site. Many times the transplant never comes. There's never a suitable match for that patient, and so many times they actually pass away before that they can actually get the transplant that they need. And so ventricular assisting devices are helping to alleviate this simply because they take the pressure off of the heart and allow it to kind of function a little more at a higher level until a transplant is allowed or acquired. And so these will become, I feel, the new norm that we'll see for patients needing cardiac transplant to prolong their life. So aortic aneurysms. The aorta is about the thickness of a garden hose, and it runs from your heart through the abdomen. An aneurysm is a circumscribed dilatation or stretching of an artery. While we know that vessels are intended to stretch, this occurs when they are stretched farther than normal. So there is a certain limitation for how far the vessels can stretch. And once they exceed that boundary, then we see that aneurysms can occur. An aneurysm involves all three layers of the arterial wall. We have the interior, which is the intima, the middle being the media, and the exterior being the adventitia. So one key thing to memorize is what is being circled right now. Know that it affects all three layers. It can't just be two layers. Typically, two layers, when two layers are affected, that is when you have aortic dissection. So, most aortic aneurysms are caused by atherosclerotic disease. It causes weakness in the vessel wall. A stenosis causes pressure to build up in addition to restricting blood flow, thereby causing an aneurysm. It allows dilatation because of increased intra-aortic pressure. The way that I can really explain this to you is if we refer to a vessel here, and inside this vessel we do have plaque. And so I realize this is a very crude drawing, and I will apologize for that. But we do have tons of fluid, which we know to be plasma here. And this plasma is reaching this point of restriction, and in this point of restriction we have just a little bit of blood that can actually go through. And in this we see that it's almost like a pileup on the interstate. When you have a wreck on the interstate, pretty much what happens is that you're restricted down to one lane. And if you're restricted down to one lane on the interstate, then basically you've went from 4 lanes to 1 lane. Then it creates a massive pile up, or a massive traffic jam there. And because of that, only just a small amount goes through, and everybody is backed up. Well, in the case of blood has to go somewhere. And so many times in that case, we see that the vessels actually stretch to accumulate more blood. And so around the site of stricture, we have the artery actually stretching to accumulate this influx in blood and to hold it. And it pushes the artery out and stretches it to the point to where we have an aneurysm. And that's really how it occurs. And it's important to understand that up to 9% of the population of the United States older than 65 have an abdominal aortic aneurysm. So up to 9% of patients 65 and older. So that's a very high incident rate there for that. And we also must remember that a slow growing thoracic aneurysm generally does not rupture, but large fast growing aneurysms may. So remember, slow is okay, fast, very bad. Also, the risk of rupture really depends on size. Less than 5 centimeters in size, there's only around a 5% chance of rupture. Greater than 6 centimeters, so in between 5 and 6 centimeters, there's about a 16% chance. Greater than 7 centimeters, there's a 76% chance of rupture. So pretty much if you're above 7 centimeters, it's going to rupture at some point in time. A rupture of an aneurysm has a high mortality rate, around 77 to 94%. Very high. So therefore we have to assume that if it is rupturing, then your chances of surviving it are very slim. Aortic aneurysms often grow slowly and usually without symptoms, making them difficult to detect. Many times the only time that you'll have symptoms are when there's actually a problem there. Some aneurysms will never rupture. Many start small and stay small, although many expand over time. Some aortic aneurysms enlarge slowly, increasing less than half an inch or 1.2 centimeters a year. Others expand at a faster rate, which increases the risk of rupture. So if we look at this though, if you increased a half an inch, it wouldn't take very long to actually achieve the 7 centimeters though. And so over the course of time, you will have to have that repaired as well, just not as rapidly. So the etiology of aortic aneurysms. The exact causes of aortic aneurysms are unknown. However, many factors are believed to be a contributor to them, and these can be Marfan syndrome, Ehlers-Danlos syndrome, defects with the heart valves, previous injury to the aorta, and atherosclerosis. And so what we're going to focus on is simply atherosclerosis, simply because that really seems to be very prevalent in a lot of patients who have aneurysms. So symptoms of an aortic aneurysm. Some typical symptoms are tenderness or pain in the abdomen or chest. You'll see it a lot of times, a lot in the abdomen. Back pain radiating to the back, corresponding with this abdominal pain. Many people chalk it up to just a hard day at work, things like that, while it could be that it can also be an aneurysm. We also have abdominal pain, and then the real key factor for those abdominal aortic aneurysms is a pulsatile abdominal mass. Many times physicians actually report that they can hear a pulse if they put their stethoscope, or they can actually place their hand and feel a pulsatile abdominal mass. And because of that, they're almost certain that there is an aneurysm. So the workup for diagnosis. Number one is a chest x-ray, which sometimes we can see ectasia and maybe slight dilatation of the aorta. However, many times chest x-rays are just not detailed enough to provide what we need. Echocardiogram, routine ultrasound, chest abdominal CT, and magnetic resonance angiography, or an MRA. However, one of the really key factors that make CT the best choice among these is the sheer amount of time that it takes to acquire the scan and process and actually send it out for a reading. Many times, depending on the operator of the CT machine, the chest, abdomen, pelvis can be done in 10 minutes and under, allowing the images to be processed and read very rapidly, whereas magnetic resonance imaging, routine ultrasounds, and even echocardiogram may not be able to be done in that rapid fashion. Many times echocardiograms will take 30 minutes to perform, 30 minutes to an hour I should say. Routine ultrasounds many times are subjective based on the abdominal contents, and magnetic resonance imaging, while excellent, tends to take a little longer. So that means that chest, abdomen, pelvis, or chest abdomen CTs tend to be very rapid, and we can actually get a result immediately. Okay, in this image we do see that this is a contrast enhanced study. Judging by the spine, the vertebral bodies here, and what looks to be some calcifications here on the spine, it would be safe to say that this patient is probably an older patient, probably in that 65 or older area. And we do see that we have the aorta here, and then adjacent to the aorta we have the inferior vena cava. Notice the size of the aorta in respect to this inferior vena cava. We should also say that measurements would be taken of the aorta in this fashion and this fashion to actually demonstrate how wide the aorta is. While this aorta is not overbearingly wide, we do see that it is something that needs to be watched. And also, we do see that this patient probably has atherosclerotic disease because we do see calcifications lying around
the aorta, although it's very difficult to discern based on there being contrast enhancement in this study. However, we do see that this provides a very good indication of actually what an aneurysm looks like. And if we were to look at the bowel contents here and here, and even through here, we would see that it'd be very difficult for routine ultrasound to actually acquire these images, and echocardiogram would not be entirely applicable here, and so it would be very much needful that CT be performed. And so we can see the CT does an excellent job in this. Okay, this image is a little more dire. I first want to point out that we do have atherosclerotic potential disease here based on these calcifications, and so it would be safe to assume that this patient probably does have some plaque in the arteries at some point. We also see that there is a lot of mesenteric stranding here. We're not really sure what this is, but there's a general haziness around the aorta. We also must understand that something is going very wrong with this aorta, because we do see what looks to be a bulge within the aneurysm here, and if we'll notice, we're at the level of the left iliac crest, and so this would mean that we're getting close, or we should be seeing bifurcation. And so we could potentially say that this is where the bifurcation is going to occur, and one of our iliac arteries has a very large aneurysm. However, it's difficult to discern. What is not difficult, though, is the size of this aneurysm. We must presume that this one is a little larger than the previous one that we actually looked at, and because of that, necessary means to be proactive in this would need to be taken. Many times when physicians see this, the patients are automatically sent out simply because it's better to have it repaired while it's not leaking than attempt to repair it while it is leaking, because mortality rates skyrocket for that. On this image, there are a few things that I would like to point out. Number one is that we have a Greenfield top filter here for the superior vena cava, and so based on this information, we can say that this patient maybe has a tendency to actually develop clots, and because of this, it can be very detrimental for the patient. So also, we do see that we have plaque here and even here. And so we do assume that the patient does have atherosclerotic disease. But another thing that will give us the age of the patient is we have some calcifications here on the spine, and based on this could be subjective to the imaging technique, or it could just be due to osteoporosis. But we do see that the vertebral bodies do have a loss of calcium there, and so potentially that this is an older patient. However, we do see that we have an aneurysm here. This aneurysm is very detrimental and can be very difficult to repair simply because of the location. So this is an aortic arch aneurysm. Keep that in mind. And it must not be confused that aneurysms have to happen in the abdominal area here, because they can happen virtually anywhere on the aorta. They can happen at the ascending aorta and even continue into the descending aorta, which runs through the abdomen. In this demonstration of an aortic aneurysm, we see that something is very peculiar here. We see that this is the ascending aorta and the aortic arch here. And we also see that just adjacent to it on the left-hand side, there is this area. And we must presume that this is
an aneurysm of the aortic arch, and we do see that it does have a lumen on the inside here, which pretty much demonstrates how large this aneurysm really is and how intense this can be to actually rupture and cause serious life-threatening problems. And so it's very needful that this be remedied before it actually ruptures. So, aortic dissection. An aortic dissection is a serious condition in which a tear develops in the inner layer of the aorta. Blood surges through this tear into the middle layer of the aorta, causing the inner and middle layers to separate or dissect. If the blood-filled channel ruptures through the outside aortic wall, aortic dissection is often fatal. Anyone can develop the condition, but it most frequently occurs in men between 60 and 70 years of age. So remember this, that it frequently occurs in men between the ages of 60 and 70, although it can occur in anyone. So in this diagram, we see that we have pretty much a cross-section of what an artery actually looks like. We do have the intima, the media, and the adventitia. Here, notice the boundary between the intima and the media is given by the red line, and the border between the media and the adventitia are given by the green line. Typically, when you have an aneurysm, you have a tear that develops in between this layer here, and then blood fills this area and then creates a false lumen inside of it. And we'll see this bared out in many of the CT images that we will look at. So there are two types of aortic dissections, one being type A and the other being type B. So it's very important that we keep these in mind. Type A is when the ascending aorta experiences a tear in it. It's the more common and dangerous type, with around 60% of all dissections being of this type. It involves the ascending aorta from where it exits the heart at the left ventricle up to the aortic arch. So be very mindful of the percentage that occurs here and where it actually occurs. Also, type B involves a tear in the lower aorta only, which may also extend into the abdomen. This is the lesser common of the aortic dissection, comprising only 40% of cases. So basically, this compromises those aortic dissections that go from the aortic arch through the descending aorta and into the abdomen. So what causes an aortic dissection? It is believed that chronic hypertension seems to make the aorta more susceptible to tearing. Once again, Marfan syndrome, a bicuspid aortic valve, or traumatic injury can all cause aortic dissections. Typically, though, we associate it with chronic hypertension and traumatic injury being the most common forms or reasons for aortic dissection. So the symptoms of aortic dissection. Aortic dissection symptoms may be similar to those of other heart problems such as heart attack. Typical signs and symptoms include sudden severe chest or upper back pain, often described as a tearing, ripping, or shearing sensation that radiates to the neck or down the back. Also loss of consciousness, fainting, if we do have full dissection and it is actually ruptured. Shortness of breath, sudden difficulty speaking, loss of vision, weakness or paralysis of one side of your body, such as having a stroke. Sweating, also a weak pulse in one arm compared to the other. Typically, though, if we'll notice many of these symptoms, such as the sudden severe chest pain, shortness of breath, and even sweating and a weak pulse can tend to mirror such symptoms as congestive heart failure or heart attack. And because of this, many times it's an incidental finding for aortic dissection. So the way that we actually find out if a patient has aortic dissection is very simple. We can have a CT of the chest, an MRA of the chest as well, or a transesophageal echocardiogram. The reason that we tend to favor CT of the chest more than MRA is simply because of time. CT seems to be very, very indicative or very readily available, whereas MRA and sometimes transesophageal echocardiograms are not available, especially at smaller facilities. CT also provides a very quick turnaround time to where the patient can get into this computer tomography suite and have the images acquired and exit the suite and be returned to the emergency room in a very rapid fashion, and the image processed and a report given in a very quick turnaround time that's very detrimental to the patient's health and vitality. For those who have never seen an aortic dissection before, typically what we see is, I will draw it for you, is you have the aorta looking something like this, and you'll have what looks to be a line running inside of the aorta. Typically your aorta should look like this with no lines inside of it at all. And because there is a difference there, a very stark difference, then makes it readily easy and available to see an aortic dissection. So if we look at this image, we do see that this is with contrast, and we do see that we have the aorta here, and inside of this aorta we do see a line that almost resembles a half moon shape running through the aorta. This is not typical, and what we actually have here is a false lumen. We actually do have separation between the intima and the media, and because of that we actually have what looks like a division in the aorta. However, this can cause severe weakening of the artery and ultimately lead to rupture. Another thing that I would like to point out based on this image is if you look at the density of the bowel here and here, many times ultrasound and things of that nature have a difficulty penetrating this, and so it sometimes would not be very pertinent to actually to perform an ultrasound, and that's why CT has relatively become a gold standard to view aortic dissections. Okay, on this type of aortic dissection, notice the location. We are at the aortic arch in this area. We're seeing the scapula here and here, so we're just leaving the shoulder girdle, and we do see that we have a line running here in the aorta. This is type A aortic dissection, very dangerous, and as we can see, it would have a great mortality rate simply because of the location being very hard to get to and very hard to remedy. So it's very important that we actually provide quality images on this, and as you'll notice, this is performed with contrast. Without contrast, the aortic dissection would be near impossible to see. However, contrast does allow delineation between what is an intimal flap or an intimal tear of the aorta and what is not. Okay, on this one, we can notice the proximity or the location, and we do see that we have the pulmonary arteries here. We do have the left pulmonary artery coming there, and we're seeing the right here. So this means that we're slightly lower in the chest than the previous image, but one thing to notice is this area here. This will be the ascending aorta, and which makes this a type A aortic dissection. And if we'll notice, this is very detrimental to the patient's health because you're basically looking at a dissection right as the aorta emerges from the heart, which can be extremely difficult to get to and repair. And we do see other things going on in this patient's chest as well. We do see something going on here, here, and maybe even here. And because of this, it becomes questionable whether something has begun leaking out into the spaces around the heart. And it's really unknown. The only thing that we have to suggest that maybe it's not is because we have injected contrast, and due to that, hypothetically, we don't see any contrast into these spaces. This image is a little farther down. If we'll notice, we have passed through the diaphragm on the right hand side where the liver is, and we are passing through, showing the spleen on the left hand side. So this must mean that we are in the descending aorta, and because of that, we know that this is a type B aneurysm. It's one of the lesser common, around 40%. We do see that we have the aorta here, and inside of the aorta, we do see a false lumen right there. And we do see that the interior, or the true aorta here, is much more contrasted than the other side. And that can just be due to the fact of the aortic dissection. Also, we do see another thing that's going on in the liver, and we presume this to be a benign hemangioma, just based on the way that it looks. It has defined borders, and it seems to be very much benign. So our last topic is myxomas. Primary cardiac tumors are rare and occur in 0.6% of patients in autopsy series. Metastases to the heart are approximately 40 times more commoner than primary tumors, most of which are benign. Myxomas account for 40 to 50% of primary cardiac tumors. Approximately 90% are solitary and pedunculated, and 75 to 85% occur in the left atrial cavity. Up to 25% of cases are found in the right atrium. So keep that in mind. For the left atrium, we do have 75 to 85%, and for the right atrium, we have 25%. So it's going to be greater on the left than the right. Although atrial myxomas are typically benign, local recurrence due to inadequate resection or malignant change has been reported. Occasionally, atrial myxomas recur at a distant site because of intravascular tumor embolization. Left atrial myxomas produce symptoms when they reach about 70 grams. Right atrial myxomas grow to approximately twice this size before becoming asymptomatic. Tumors vary widely in size, ranging from 1 to 15 centimeters in diameter. So we must see that the right atrium myxomas can get much larger than the left atrium myxomas without occurring or causing symptoms. Based upon the data of 22 large autopsy series, the prevalence of primary cardiac tumors is approximately 0.02%, or 200 tumors per million autopsies. About 75% of primary tumors are benign, and 50% of benign tumors are myxomas, resulting in 75 cases of myxoma per million autopsies. So we must assume that based on this number, 75 cases per 1 million autopsies means that the cases of myxoma are very, very rare. Sudden death may occur in 15% of patients with atrial myxoma. Death is typically caused by coronary or systemic embolization, or by obstruction of blood flow at the mitral or tricuspid valve. And so many times what occurs is the myxomas get so large that we have obstruction of blood flow. And because there is obstruction of blood flow, the patient dies due to this. So what causes myxomas? Most cases are sporadic. Approximately 10% are familial and are transmitted in an autosomal dominant mode. So remember that up to 10% are autosomal dominant in transmission. Multiple tumors occur in approximately 50% of familial cases and are more frequently located in the ventricle, 13% versus 2% in sporadic cases. So many times these familial cases will cause multiple tumors, and they will be located in the ventricle instead of the atrium. So, symptoms of myxomas. Symptoms range from nonspecific and constitutional to sudden cardiac death. In about 20% of cases, myxoma may be asymptomatic and discovered as an incidental finding. Signs and symptoms of mitral stenosis, endocarditis, mitral regurgitation, and collagen vascular disease can simulate those of atrial myxoma. A high index of suspicion aids in diagnosis. So, symptoms of left-sided heart failure. Dyspnea on exertion, around 75%, that may progress to orthopnea, paroxysmal nocturnal dyspnea, and pulmonary edema is observed. Symptoms are caused by obstruction of the mitral valve orifice. Valve damage may result in mitral regurgitation. Symptoms of right-sided heart failure. Patients experience fatigue and peripheral edema. Abdominal distension due to ascites is rare, however it is more common in slowly growing right-sided tumors. These symptoms are also observed in the latter stages of progressive heart failure associated with left atrial myxomas. Patients can also have severe dizziness and syncope, which is experienced by around 20% of patients. Also, you can have symptoms related to embolization. A systemic or pulmonary embolization may occur from left or right-sided tumors. Left-sided symptoms are produced from the infarction or hemorrhage of viscera. Embolization to the central nervous system may result in transient ischemic attack, stroke, or seizure. So how do you find myxomas? Typically, lab tests are non-specific and non-diagnostic in quality. A chest X-ray may allow you to see an abnormal cardiac silhouette, but sometimes this is not always the case. Also, an echocardiogram, if something is actually suspected with internal mechanisms of the heart. MRI, which is better than CT in finding point of attachments. CT chest differentiates the characteristics of myxomas from the intracardiac thrombus. And so we see that both MRI and CT play a role in diagnosis. CT chest used for the initial means to just differentiate a thrombus from other things such as myxomas, so that treatment can begin. However, if the initial diagnosis is a myxoma, then MRI is performed because you can actually find the point of attachment before you actually go to surgery. So both play a role in the diagnosis and treatment of myxomas. So what does myxomas actually look like on CT? Well, you must first realize that the most frequent location, around 80% of the tumors, is the interatrial septum, more commonly on the left side than on the right side, meaning that it's more common on the left of the left atrium than on the right atrium. On pre-contrast scans, the tumors have a heterogeneous, low contrast or low attenuation, and calcifications are common. After contrast administration, intense enhancement can be seen, but more often enhancement is heterogeneous. In terms of looking at this image, we do see that we have a myxoma here, and there might be some confusion as to where this actually is. So one clue that will actually kind of give this away is we look for the presence of pulmonary veins. If there's an absence of the pulmonary veins, then many times it will be in the right atrium, since there are no pulmonary veins coming out of the right atrium. So we see the pulmonary veins being here. So that is one thing that will actually give us the clue to where this is. Also, if we know the proximity or where the left atrium is, we know that it is just anterior to the vertebral bodies of the thoracic spine. And so we see the vertebral bodies here, and just anterior to it is the left atrium. And so this would fit with what we know to be the case with myxomas. So just be on the lookout for that. So if you're looking at this from your slideshow, there might be slight confusion as to where this actually is. This actually appears to be in the right atrium, and we do see it here. Here's another right atrial myxoma. We do see it here. One thing to keep in mind based on this image is we do see some kind of ghosting here coming there and here, making the tumor actually appear larger than what it actually is. And so the actual tumor size is probably around this, but we do see the ghosting simply because of the pulsation artifacts of the heart. But notice that we do have a myxoma in the right atrium here. And so once again, right atrium myxoma. If you have any questions or comments, feel free to send me an email at tmassengale0002@kctcs.edu. Thanks.